Good afternoon, everybody. Today's lecture is part of the series of POGS webinar Connect with Experts. This is the Pune Obstetrics and Gynecological Society's initiative of webinars. Today, I, Dr. Harshad Parasnis, President of Pune Obstetric Gynec Society, and Dr. Ashwini Kale, General Secretary of Pune Obstetric Gynec Society, will conduct this program. And today's topic is managing second trimester anomalies. Amongst teachers, there are few who are skilled and popular in the art of teaching, and one of them is Professor Ashok Khurana. Professor Ashok Khurana is an alumni of All India Institute of Medical Sciences. He's done his MD in radiodiagnosis, in AIIMS, New Delhi. He has been trained at the Herlev Hospital in Denmark in ultrasound. He is a chairman and consultant in reproductive ultrasound at the Ultrasound Lab, New Delhi, and has been practicing ultrasound in New Delhi since 1980. He has authored many books, but two noteworthy among them are two medical textbooks that he has authored: 3D and 4D ultrasound, a text and atlas, and step-by-step breast ultrasound. He has lectured extensively, conducted training workshops, and chaired several scientific sessions. He is the professor of the School of Health Sciences, Dubrovnik International University, Croatia, and he is the immediate past president of the Society of Fetal Medicine. So friends, it is a pleasure to hear and to learn from his vast experience. And so may I now request Professor Ashok Khurana to speak on managing second trimester anomalies. Dr. Khurana, you may please start your presentation.
Thank you very much. Greetings from New Delhi, and it is indeed a very happy afternoon for me to be with my colleagues in the Pune Obs and Gynae Society this afternoon to share my thoughts on managing second trimester anomalies. I take this chance to thank the organizers here, and I'm very happy to be able to be in the company of Dr. Harshad Parasnis, Dr. Ashwini Kale, and Dr. Chaitanya Ganapule, and also with all of you in the room today to be able to discuss this topic further. It's a topic close to my heart because, as you know, I'm fond of technology, and we've come a long way, not just because we now have great MRI with tractography, as you see here, or that you have excellent 3D and 4D ultrasound, or that you have advances in genetics, but also because for our basic second trimester anomaly scan, we now have excellent 2D resolution, as you see here, where we can identify very nicely the echogenicity of the lung separately, quite separate from that of the echogenicity of the liver. You can see the bowel separately. You can see the blood vessels coming in here, the urinary bladder here, the spine seen clearly, and all of this seen in a single frame. And these are the things that have really helped us to produce far more information. And I want to interact with you today and show you how we use this information and how the information that is available to you today should be used to make sure that every fetus has a good outcome. And so let me start with, I'm trying to get my slide to change, and we have, there we are. We have the first thing that I always like to start with is this business about where do we stand with anomalies. And if we look at an 8-year-old paper from the WHO, we realized that the incidence of anomalies is high, about 1 in 33 infants, and these result in approximately 3.2 million birth defect related disabilities every year, which is really, really a difficult situation. Also, we have a huge neonatal mortality, and in the first 28 days of life, we presume that about a little over 2.5 lakh newborns will die from congenital anomalies all over the world, which is really a huge number, and we need to do something about it. And for the ones that survive, we have the problem of a long-term disability, which may have significant impact on the individual's quality of life, which will have an impact on the families, on healthcare systems, whether they be private or public, and of course on society at large and the community where the actual baby or the individual is going to be growing up. And so we truly need to do something about this. And the one thing that we have learned is that yes, there is the possibility that we pick up a large number of these, and not that it's necessary to pick up all of them, but the ones that get born, we have to be ready for them. We have to let the patients know what is to be done for them. And also in case the patient decides not to carry on with the pregnancy, what is the justification and what is not. We know that some of these will result in a loss rate, either miscarriage or a spontaneous miscarriage, fetal demise and intrapartum deaths, but a lot of them will survive. And therefore we need to know exactly how to use this information. And the information is improving every year. So whereas in the 80s and the 90s, we had a 39% prenatal detection rate, we now understand that we now approach a 90% detection rate for fetal structural malformations in the mid-trimester or the second trimester anomaly scan between 18 and 20 weeks. There's no doubt that in some systems, very few, that is about 15%. And this is what that is. Some of them are late onset abnormalities. Some of them are too subtle to be picked up. Some anomalies, such as a patent ductus arteriosus, will never be picked up. And on the other hand, like for neural tube defects, we're actually picking up 99% of these abnormalities at this time. And therefore, we feel quite happy about it. And we do realize that about half of these are actually being picked up now in the 12 to 14 week scan. But what remains the mainstay of abnormality diagnosis is the 18 to 20 week scan, which in the West they call the 18 to 22 week scan because they don't have an MTP law like ours, which insists on the 20-week deadline. What we have to do is to see them about 18, 19 weeks so that at least you have a week or 10 days for decision making. And so I'll take you through the protocols with how we do these scans and how we get this information, the ultrasound diagnosis of these anomalies, the associations and the prognostic features, which are so necessary to make a complete diagnosis, because truly speaking, that is where we have to really put in our best, because it's prognostication which is far more important than just the diagnosis. There is a natural history to these for which we have to have knowledge. And so I will discuss a bit on obstetric management and a bit on postnatal management. But it's not going to be a how to do guide for all anomalies, because I think there are enough webinars on that. How do we do a mid-trimester anomaly scan? How do we move the transducer? How do we prepare the patient? That is beyond the scope of today's webinar. And I'm certainly not going to make it into an atlas where I say, okay, A, B, C, D, E, F, G, H, and not do justice to any. I've picked a few more common anomalies, a few representative anomalies, and also some where we do realize that things have changed rapidly and we need to change our approach. Also a set of anomalies where thinking can be tuned, so that even if we haven't heard about that in today's webinar, you will realize that this is how we ought to think when we are trying to sort out an anomaly between the anomalous fetus, between the parents and the entire medical population. How should we interact? What should be done? And essentially a practical guide for our day-to-day scenarios. So let's move on with that and see where we started all this. We started all this in the late 70s. And prenatal diagnosis at that time concentrated on two things. One was neural tube defects, because that was the most common anomaly then in the West. And the second was Down syndrome, because that was the most common cause of mental retardation in the newborn, which was a congenital mental retardation. And for many years, that's the only two things we looked at, NTDs and Down syndrome. Today, we have moved on beyond that. The NTDs, when they started off, was a scan which was confined only to exclude open neural tube defects. So the patient used to come in the 70s for a level 1, which was a dating scan at 14 weeks of gestation. Then they used to go back and have a lab test for serum alpha fetoprotein only. And the ones that had 3 times greater, now we consider 2.5, but those days it was 3.3 times greater, used to come back for neural tube detection at 16 weeks. And therefore, this is called the level 2 scan. This word, unfortunately, has hung around in our vocabulary far more than it should. Because truly speaking, the level 2 scan was only for open neural tube defects. It was done at 16 weeks and the detection rate was 60%. We moved beyond. We have today all the systems under review, we no longer should call it the level 2 scan. We should call it the mid-trimester anomaly scan or the second trimester anomaly scan. And of course, we look at much more than anomalies. We look at whether the fetus is alive or not, of course. The number of fetuses in case they've been missed earlier and there is more than one fetus. And if we find two, we look for the third one and so on. We do biometry to check the growth as well as data pregnancy in case the patient has not had a scan before. We watch movements, cardiac activity. Of course, the bulk of it is and then we also do a maternal anatomic survey to assess the cervix. We look at also the myometrium, we look at the adnexa and so on, fibroids, dermoids, which might have an impact during the perinatal period or during the pregnancy. And of course, today we always do uterine artery Doppler just to make sure whether we can salvage any of those that might benefit from intervention or an increased surveillance. And therefore, we have an expanded agenda, and it's no longer the original level 2. So let's move away from the word level 2 and move on to the anomaly scan. Now, the first thing we realize is that we need protocols or guidelines on how to do the scan, and obstetricians need to be aware of this because you must know what is possible, what is being done, what has been done by a particular person who's done the scan in case you're not doing your own scans, and what can be missed. Also, how is this far away from ideal? And therefore we have guidelines and we follow those. You have protocols are basically something that tell us that if you follow them, you will get an adequate examination most of the time. And then of course they can protect you in a medical legal situation. And that is equally important because today we must understand that the judiciary that we have to handle is the consumer court. The consumer court typically would have 2 or 3 people and sometimes only one, and they may not have a judicial background. They might just be distinguished citizens, and therefore we have to be careful that yes, and therefore then this becomes quite important. Now, when I look at all the protocols, I do understand that there are many protocols that are available, and we should be using those. But the fact is that you and me have to choose which would be an ideal protocol. And if we go by the ones from the Royal College, they do fall short of a very detailed anomaly scan. If we go by the Fetal Medicine Foundation of the United Kingdom, they may not be appropriate for us because they're done by specialists. What we need is a doable ones, and the 2 doable ones that you will come across are those from the Society of Fetal Medicine, which is a global forum of Indian origin, and we also have ISWA guidelines, which are from the International Society of in Obstetrics and Gynecology. And therefore, these are the 2 I usually like to follow in my routine work. And I like to follow the Society of Fetal Medicine guidelines because they actually help me to do this best of all. I'm trying to make sure why my slide is not slipping onto my next one, and I should be able to spot that in a few minutes. And there we are. There we go. So the 2 that I normally recommend are the Society of Fetal Medicine guidelines, which were in 2014, or the ISWA guidelines, which are a little older, which is 2010. And both of these are available as free downloads on the internet, and you can go through them. And when we go through this kind of checklist that you will find, one is this one, which is the Society of Fetal Medicine guidelines, which takes you through the whole anatomy. And it tells you the specific structures that you need to look for. So we look at the head, we look at the face, we don't forget the neck, we look at the chest and realize that it is not just the heart, but other things as well, including the lungs and the mediastinum and the ribs. The abdomen, where it's not just a question of stomach and urinary bladder, but other things as well, including the cord insertion site. We look at all parts of the skeleton, both the axial skeleton and the pendicular skeleton, and all the way down to hands and feet. So finger counting may not be part of the protocol, but in certain situations, we like to look for it. For instance, in Down syndrome screening, I will look for clinodactyly or a sandal gap. If I find something wrong with a previous history, I will look for polydactyly and so on. And then, of course, we also look at placenta and umbilical cord. the genitalia may be looked at in specific situations when you have to do problem solving. And because of sex-linked conditions, and these are very well known, and the PCP and DTI clearly say that, look, if it is necessary, you have to see it. So in a posterior urethral valve, I know I have to differentiate it from a urethral atresia, so I will need to look at whether the external male genitalia are well formed or not. And I may not disclose it to the patient, but it helps in my diagnosis. And in a certain way, you can mention it in the report. Very often, it also depends on your local atmosphere, which means that if you have a good relationship with the PCP and DT authorities, and they're tuned to what things are all about, then they will allow this. But they're also fearful of misuse, so you must understand their position as well. And therefore, you have to realize what it is in your particular district and use this information accordingly. Now, one thing that we always emphasize in these protocols is this, that these represent a minimum practice guideline, which will help us to minimize the number of missed abnormalities. Now, sometimes there are, or many times there are institutions within our own nation that have a limitation, and they may not have expertise and equipment, which means they have resource restriction. Not enough money to run a department, they will be understaffed. Equipment may not be absolutely up to the mark, it may be low-end ultrasound rather than high-end. MRI may not be available, genetics may not be available. The important thing is that every institution has the right, according to all these protocols, to form its own institutional protocol, which means that you and me can say that, look, because of the pressure of the number of cases, of expertise, you and me definitely can reduce the protocol, and therefore we give only this much. But we mentioned it in the report that, look, we have tried to follow the Society of Fetal Medicine guidelines or XYZ guidelines, but they are abbreviated because of resource restriction, and we cover only this, and you can put it as part of the report. And that is the best way to avoid a misunderstanding for future reference, because there's no doubt that everyone expects the world's best in terms of expertise and equipment. And in our part of the world, they don't want to pay for it. Until we can change the mindset, it is wise to put everything down in a written report. And that is the first lesson of managing ultrasound scans and the anomalies. That we mention limitations in the report, and then move in from there. We also mention what is the protocol that you're following so that people would know what to expect. Now, the next question to be answered is, who should have one? Is there a high risk group? Is there a low risk group? That does not apply to the anomaly scan. All pregnant women at 18 to 20 weeks should be offered it. And we now have a directive from the Ministry of Family and Health and Family Welfare 2 years ago. It was put together by Dr. Prathama Mittal from Delhi, and she works at the General Hospital. And she said, this is the one scan that seems to be the right of our patient, and we should be able to offer this. Yes, we may not be able to offer it. In that case, it should be mentioned on the patient's card. But the patient should be offered this, and he said, look, if our institution is not offering it, please get it done outside on your own. If you can't afford it, we'll understand, and then we will just pray to God. But everyone should be offered this scan, and outside the institution, if not within the same institution. Now, when should this scan be done? 18 to 22 weeks is a good time, and the later we do it, closer to 22, we do realize we see a lot more, and embryology also moves on, so structures get a little bigger. Some structures like the corpus callosum will become complete. The posterior cranial fossa might become more clear. Cardiac anatomy might become better. There's no doubt that earlier scans date better, but earlier scans require equipment, they need expertise, they have time, and therefore that is the downside. So what we really need to do is that do a later scan, because they can see more. But do remember that if you do it too early, for instance, here, I am looking at a situation where at 16 weeks, I'm able to pick up only 30 to 40% of the anomalies that I can actually pick up when I do my scan at, say, 22 weeks. At 22 weeks, I would pick up on an average 70% of all anomalies in a routine clinic, not a highly expert clinic or a fetal medicine clinic. And we have to talk about not a fetal medicine clinic. After all, we have to cater to a population. So the later we do it, the better it is. And 17 means about 50%, 18 means that you will pick up about 60%. And therefore the earliest we should really do these is 18 weeks. Now we have at the moment the MTP Act, a new one to be passed by Parliament. It's been passed by the Lok Sabha. We're waiting for the Rajya Sabha results as and when the Parliament sits. And then we will be able to realize that yes, we will be able to see patients up to 22 weeks or later, because for abnormalities, there is no limit in the new rules on when you can terminate a pregnancy. All we have to do is to go to a district court, not the high court, the district court, which will give instructions to go to a general or a district hospital or a civil hospital or a teaching hospital close by, where the entire decision on whether a patient can be allowed to terminate an anomaly will be taken within a week. And the patient doesn't have to run around. All they need is either self-resources of approaching the district court, or a good lawyer who can do this for them. And that would be of the to effect and notification. If too early you miss something, you do them at 19 weeks, 4 days or 5 days, you realize that there's not enough time for the patient to understand. There's not enough time for further investigations. You do realize there's not enough time for actually counseling the patient enough and coming to conclusions, and it's all rush. And therefore we say, okay, 18 plus 5, 19 plus 1 seems to be a good time, and that's what we like to follow. There are some situations where we actually have special situations where we might like to consider an earlier scan than 18 to 20 weeks. For instance, if you have a doubt in the early morphology scan between 11 weeks and 13 weeks, 6 days, or you have an abnormal first trimester biochemistry, a normal ultrasound scan at that time, then you might want to follow them faster. If there is a past history of a specific malformation, an earlier diagnosis is or you have an abnormal second trimester genetic screen, such as a high alpha fetoprotein, might consider this earlier. And of course, every mother has the right to make such a request. And therefore, it's a good idea to actually then carry out a scan somewhere between 14 and 17 weeks, and 16 weeks seems to be a good idea. But it does not mean that the 16-week scan will not be also complemented by an 18 or a 20 scan. Both need to be done. The 18 to 20 week scan needs to be done for everybody. In some patients, like the ones mentioned, you might consider a normal scan at 16 weeks or any time between 14 and 17 weeks as well. Now, remember that there are limitations, and these are important from the patient's understanding point of view, and these are important also from a legal point of view. And the radiologists, the sonologists, the experts in fetal medicine, as well as the practicing obstetrician need to understand that these are limitations. And one of them is gestation age, which we've discussed. We do understand that we can't wait too long for this, because after 26 weeks, there's bones which actually stop visualization of the fetus, particularly the thorax and abdomen. Or the fetal attitude might be curled up, and you may not be able to do such a good scan later in pregnancy. And therefore, an ideal window is 18 to 22 weeks. Then, of course, fetal position, like we've already mentioned, oligoamnios, which really is the biggest enemy. And sometimes we're going to the extent of saying that, look, please mention in the report that there's oligoamnios, inadequate visualization, and could we please repeat this scan at a reasonable period of time, say 22 or 24 weeks. Then there's equipment considerations, so that not everyone can have the best equipment, and this should be mentioned in the report. And there is expertise, that the people who do scans should be truly experienced. In our part of the world, qualifications are governed by the PCP and DT Act, and so we're not too worried about that situation. But in other parts of the world, expertise is a special certification. In ours, anybody who has a postgraduate degree in radiology or a postgraduate degree in obstetrics and gynecology or an MBBS with a 6-month special course approved by the government can do an anomaly scan. Now, moving on, we also need to remember one more thing, which is very important in looking at anomalies, managing them, understanding them, and that is that there's an embryological timetable, that there are certain parts that will not be seen at 18 to 20 weeks, and that is, A, the cerebellovermis and cisterna magna might show a large communication between the cisterna magna and the fourth ventricle as late as 18 to 19 weeks. And this needs to be taken into consideration. The corpus callosum may not be formed all the way to 22 weeks, and therefore you might consider looking for the corpus callosum or the cavum septum pellucidum again in case you weren't satisfied at the 19-week scan. Microcephaly is something that happens later in pregnancy. We can't pick it up. Out of the skeletal dysplasias, the most common, achondroplasia, may not be evident until 26 weeks, and therefore we will not pick it up during it. It's probably only as good as your last missed finding, isn't it? So what I normally suggest is that it is nice for us to be sure that yes, we do remain aware of these, and obstetricians should say, well, we don't have 100% detection rate, and perhaps it could have been picked up, but maybe the position was not all right, and so on. Then there are bowel atresias and urological disease which are dependent on swallowing. So if the fetus is not swallowing enough, which it really doesn't until much later in pregnancy, you may not pick up a duodenal atresia at the 18-week scan. Or you may not pick up urinary obstruction until about 24 or 28 or 32 weeks. And so these are the things one must keep in mind, that look, was this the reason that a finding was missed? And the practicing obstetrician, the general obstetrician, should be aware of this, and that is truly part of the wise management of congenital malformations. Now, there are situations where it is obvious to the person doing the scan that this is something that is just not matching up. What do we do then? Well, the person who's doing the scan must mention in the report that, look, maternal habitus, because that's one of our biggest enemies in doing a scan, or too little fetal age, or too advanced fetal age, or fetal attitude interfered with good visualization, and we would like a repeat. And then that is the best way, and you schedule this and you can mention it in the report. That's what I do, that look, the visualization of the cavum septum pellucidum was inadequate. We cannot exclude an agenesis of the corpus callosum, and a revaluation is suggested at 22 weeks. And this has been scheduled with the patient for such and such a date. I like to mention that all in the report, and then we mention it in the conclusion as well, so that there's no misunderstanding. A patient may choose not to come back, or a patient might change town, and then tomorrow you hear from their attorney that, look, something has gone wrong, which is not nice. After we did our best. So it's nice to document all this and not just talk to the patient about this. Or if you feel that, look, my equipment may not be good enough, or I'm not feeling too good today, send it to a colleague, and maybe they'll be able to do a job. And then you indicate exactly in your report the reasons for referral, and mention in your report also, you always give a report on any patient you see, that I took a look at this patient, I've found suboptimal visualization, and I feel that a second opinion might give a better result, and therefore I'm referring the patient to such and such person, and they are requested to contact them as soon as possible. All this should be written and documented to stay away from trouble. And this is truly the secret of managing abnormalities, that tomorrow if something comes up inadvertently, you are protected by yourself, and the patient is aware that yes, there are limitations, and every effort was done to make sure that this limitation was limited. Do remember that the purpose of this scan is to provide accurate diagnostic information for the delivery of optimized antenatal care, and the best possible maternal outcome and the best possible fetal outcome, and not just terminating every pregnancy with a finding. There is a tendency, especially with Asian patients, Indian patients as well, that They don't want any baby with an abnormality, any abnormality. And they refuse to accept the fact that post-termination of a pregnancy, you never know who may never conceive again. And so we find instances of a clubbed foot being terminated without any further investigation. We find cleft lips being investigated even if there's no cleft palate. And we find small VSDs being terminated for no reason because the patient doesn't want the hassle and they presume that secondary infertility cannot happen to me. And so this practice should be stopped, and we must, each one of us at our own level, ensure that the patient understands that yes, we shouldn't be doing things this way, and we should have a approach where we give the fetus an optimal outcome. Yes, we give the patient all the options. If they want to terminate, that's the patient's choice. But you and me cannot encourage termination in these situations. And in fact, it's nice to always have non-directive counseling. Don't tell the patient what to do, but tell the patient these are the possibilities. And therefore, now you decide what you would like to do. And then if whatever they prefer, that is their choice and they have a right to ask for it, then you provide it. Now, let's start with the head. And the oldest thing we ever learned was that if you have a prominence on the sides of the head and you have a front shape like this is the classical lemon shape of the Western lemons. And therefore, you have to then look for a neural tube defect. And so what do? We start looking further down. We go down to the spine and we try and get a anterior spine. We go down and we look at it. We confirm the ventriculomegaly. We go down and sure enough, here you find that there is a soft tissue mass, an open neural tube defect, and an associated vertebral abnormality. And so you realize that the shape of the skull can tell you about neural tube defects. And you could have a lemon-shaped skull, you could have a strawberry skull, or you could have other shapes. For instance, this strawberry skull we know is the classical sign. It's a small strawberry-shaped skull of trisomy 18, or an early clover leaf, as you see here, four-sided skull, which could be the mark for a thanatophoric dwarfism. And therefore, you start thinking in terms of this, and this, of course, is the classical lemon. So the shape itself is what you need to start with, and then you also look at size by measuring it. You try and look at sutures and make sure that they're not prematurely fused and so on. And you look for integrity. The integrity means that the bones here, A, of course, will appear bright. B, that you can see space between the bones, which is sutures. And if you see any space that is not in the place of a suture, you start looking at it very carefully, because then you know that you're picking up a meningocele here or an encephalocele here, like you see here. Irregular occipital bone here, and a space through which the meninges have herniated. Remember that if you find only meninges at 18 weeks, you might get entire brain there at 26 weeks. So don't presume that what you see at 18 weeks will be like that. But again, all of this comes because you're going step by step. That the person who's done the scan is looked for the presence or absence of a skull. They look for ossification of bones. They look for sutures. They look for continuity. They look for shape. And of course, they looked at intracranial contents also. And this is what imported lemons look like. They don't look like nimbus, which are actually limes. And you have a nipple-shaped structure in front, and that's what the LTD structure looks like. We also have the banana sign, which is the flattened cerebellum. It's a small flattened cerebellum. And it happens because fluid leaks out from the posterior cranial fossa into the spinal subarachnoid space and then out into the amniotic fluid. And that is where you end up getting a banana shape. And that again becomes an indicator that you have to look. So sometimes the clue for malformations lies in finding a cardinal sign that might actually guide you to the actual abnormality. The other consideration is that when we look at the actual abnormality in a neural tube defect, it's not just, okay, there is a lumbosacral spina bifida. That's not enough. What you should expect from your report, and if you're doing your own scans, what we need to mention in our report is, yes, that there is a small or a large lumbosacral defect. It doesn't seem to have skin on top. So obviously, if there's no skin, I know this is a open neural tube defect. I then need to see where is the spinal cord terminating. So I trace the spine all the way, and then I see stuff inside the seal, and I say, okay, it's a tethered cord inside the seal. I look for the level of termination of the cord. It just doesn't terminate. It just goes on and on. There's very poorly defined spine there. I move eccentrically and I do this. And of course, I will measure the actual seal also. So that then becomes a complete report. And then we move on to look at, say, clubbed foot and measure the ventriculomegaly, look for associated defects. And then I know that I will be doing well. Remember that there are signs that not everybody looks for, but if you are an astute obstetrician, you can insist that your sonologist or radiologist or your fetal medicine specialist should specifically look for additional features, such as diamonds, pointers, and beaks, which I will show you, such as club feet, such as a bladder that doesn't empty very much, or a polyamnios, and no movements of the lower limb, because this would then give a complete prognosis. So all this information should be mentioned in your report, because that will help you to prognosticate. That will help the pediatrician and the neonatologist to prognosticate. That will help the neurologist to prognosticate far better than usual, and the patient will then understand whether they will accept this situation or they don't want to accept this situation, and then you will find everything. For instance, a lot of people seem to forget that there are subtle signs. So if I don't find a very dilated lateral ventricle like this, it's not really more than 10 millimeters, I should find a large amount of space between the end of the lateral ventricle on the occipital side and the extent of cerebral parenchyma there. If I don't find this much and I find a pointed ventricle with reduced amount of cerebral parenchyma, this becomes a pointing sign, and I say, okay, I need to look for a neural tube defect. If I find a diamond in the middle here, I know that the neural tube defect is associated with midline abnormalities in the fetus, and therefore there is an interhemispheric cyst over here, or it could be a very high third ventricle if there is an associated agenesis in the corpus callosum. And so therefore you find that yes, that is another sign, and that's called a diamond sign. And then this one, where the cerebral peduncles, instead of being blunt, actually have a sharp outline going upwards, a sharp pointed thing, and this margin, instead of being rounded, becomes concave inwards, and this is called a pointer or a beak. So this is the pointer, and this is the diamond, and this is the beak, and these are newer signs, not so new now, but you should become familiar with looking at images and saying, okay, I know this is normal, therefore this is abnormal. And it is important as we go along. After all, we've all moved on from surgery to endoscopic surgery, laparoscopic surgery, hysteroscopic procedures, IUIs, and so on. So why can't we also move on to a knowledge of ultrasound to realize whether my anomaly scan is up to the mark? So our knowledge is equally important as an obstetrician, and from a radiology or a sonology point of view, also important to look for these signs. Now, is there a role of MRI? Always consider, do I need to refer my patient and her fetus for MRI? We know that yes, MRI can add certain things in late onset visualization, such as disorders of neuronal migration. So an MRI really is ideal for 26 weeks, which doesn't fit into our thinking in the mid-trimester anomalies scan, except for early onset microcephaly, because in early onset microcephaly, there's very little window for the sonologist to look inside the head, and therefore MRI might be useful. But otherwise, MRI is much better after 26 weeks, even with good MRI, even with good skill. And therefore, it doesn't help very much with intracranial abnormalities. It may rarely show pulmonary hypoplasia or dilatation of biliary ducts. To 24 weeks. We hope in the future that we will get more information, otherwise not really. And then remember that in your report, you should look for level of the lesion. Is it thoracic? Very poor prognosis. Cervical, very, very poor prognosis. Is there a testing of the cord? Is it into the lesion? In my report that I'm reading, bad prognosis. Associated anomalies, bad prognosis. Supratentorial signs that I showed you and ventriculomegaly, bad prognosis. Underlying cause, is there a family history? Is there a genetic workup? Bad prognosis. So this is how you prognosticate. And therefore in your report, you must demand all of this. If you feel that, yes, maybe I need an opinion, the first thing to do is to call the person who did the ultrasound scan. Did you find these things? I believe I read somewhere that this is what we should know so that I can give a prognosis. That's the best way to do it. Or do I need a genetic evaluation? Call the geneticist. It's not just enough to WhatsApp or to SMS. because you might not get a reply fast enough, and patients cannot go through that agony for too long. And you don't want to lose a patient also to a second opinion. After all, you're the one who's done the hard work and discovered that for them. And they deserve you because they have faith in you in the first place. And therefore, I suggest always an immediate phone call, and someone will always call you back fast enough if they're part of your team. You always have to have people in part of your team. Some of them may not be in your own town, depending on where you are. Sometimes you might be lucky. In the Pune area, for instance, there is enough people to guide you. But in other areas, a little more further away, may not be so many. And therefore, it's nice to communicate as much as possible. And that is also essential to the management of anomalies. Now, remember that if you go through the books, it's becoming rarer. The risk of chromosomal abnormalities is somewhere between 8 to 16%, and therefore, a genetic testing before termination might be a good idea, not just a straightforward termination, and that genetics is very rare. Non-chromosomal syndromes are not so common, and the prognosis is generally very poor. So you have to prognosticate your patient accordingly. But importantly, remember that you have to keep in mind, why did this happen? Is it part of some of my single gene disorders and therefore needs not a QFPCR of fish or standard culture with karyotype? No, I need to look for a single gene defect in this particular one. And therefore, I would refer this patient for a next generation sequencing followed by a Sanger sequencing. Or in case the morphology fits into a specific disorder, then I straight away do the gene that affects me, which is I will do a Sanger sequencing. How do I handle this? I don't know too much about these conditions. I don't know about unbalanced translocations or markers or ring chromosomes. Call a geneticist. Geneticists are nice people these days. Even genetic counselors who have a background in human genetics are good. Remember that for PCP-related reasons, some people now have veterinary counselors. That is dangerous. But what you and me need to do is have a good geneticist who can guide you. Okay, WhatsApp me the findings that the sonologist has written, and I will get back to you, and they will guide you. The other thing that you have to do is to have a knowledge to realize that some common drugs might produce neural tube defects. So you might have anti-epileptic medication, virtually all of them, valproic acid, carbamazepine, etc., are known to produce neural tube defects. Isotretinoin, the anti-acne medication, is disastrous for neural tube defects, and so on. And so you need to have a complete drug history of that individual and a complete medical history of that individual. And then, of course, it will be rarely a part of other syndromes, which are not so common, and of course, fairly common in type 1 maternal diabetes, and therefore you have to have that background and investigate or question accordingly, especially if the patient comes to you for a second opinion. So do remember that good rapport with the person who's done the imaging and good rapport with genetics is essential to the management of an abnormality. The dose is about 4 milligram daily for at least 1 month prior to conceiving. We also know that our standard folic acid, the standalone folic acid is 5 milligrams, and therefore we prescribe that out of convenience. But on a general basis, for a person who's planning to conceive, 800 micrograms seems to be a good idea because our patients now have a slightly heavier BMI. And therefore, 1 month prior to conception, it's a good idea to give it. And in case they already have a history of this, of a neural tube defect, they should just not stop the folic acid until they've completed their family. And that seems to be the best answer, that we prescribe them 4 or more milligrams per day until they've completed their family. Now, remember that 3D and 4D are not primary techniques, but they're additional techniques, and therefore it is worth actually looking at them. And worth looking and seeing whether they might give more information. For instance, here, a spine done with a 3D technique called OmniView tells me not only about the spine, but the clavicles, the scapula, the ribs, the iliac wings, etc. And I realized that the ribs are short. So this tells me that it's not just a short spine, but short ribs. And you can actually play around at the levels. For instance, this shows the body of the vertebra. This shows the other ossification centers on the ribs. And this shows all 3 ossification centers very nicely. So you can play around with 3D to yield the best information, but it's not a primary technique. It's a problem-solving modality. And it can be really useful. For instance, here, kyphoscoliosis. Ordinarily, we say, well, maybe it's okay, but there were a few dark dots here, bright white dots. And a 3D showed so clearly that that was a diastomatomyelic spur. And of course, this is a post-mortem specimen. There was a split in the cord. And the other sign that appeared while this patient was going around was within 2 weeks, they got a gross ventriculomegaly. So it's important that, yes, you do use, when you spot an abnormality, for further information, you might actually want to use this kind of additional information. Now, this is the kind of information I told you is now available within a few seconds, provided the person has the equipment and provided the person has the expertise. It takes a few seconds and gives additional information. So it might be wise to request that, look, in case of a problem, please do use 3D technology. Luckily, therefore, things are changing and we don't have neonatal problems like the one shown here. We are going beyond actually my indirect signs of lemon and banana and moved on to a first trimester diagnosis. That is nice. But do remember that in spite of our first trimester diagnosis, many of them will not show up, and therefore the true anomaly scan remains the 18 to 20 week anomaly scan. The spine can in fact be seen very early as about 11 weeks, a bit, but not enough for a diagnosis. So we don't overdiagnose at this window. We truly try and be very sensible and diagnose at a much later window. Now, remember that 3D will allow you not only bones, but it will also allow you surface. And that might be useful because a subtle lesion might only be picked up in a surface rendering 3D. But more than that, a good 2D scan remains the mainstay. For instance, here, we find that there is a little nuchal edema. I don't see a spine completely, but the moment I move to the side, I realize that the amnion is lying completely collapsed. So this is obviously an amniotic band that is resulting in trouble, and therefore I would treat this differently, not just as an isolated spine defect. Moving on to the next condition, let's look at ventriculomegaly or dilatation of the lateral ventricles. We measure it, and if it is between 10 and 15, and more than 15 is what we classify as mild or severe. We used to previously have a moderate one also between 12, 13, and 14. We don't use that anymore, but we just say, okay, less than 15 mild and 16 and more is severe, and therefore you need to investigate. You in fact need to investigate both. And what will you do? The first thing to make sure that it's measured correctly. So look at the image, and you must become familiar with this. Look at the image. Have they got a true image which shows the cavum septum pellucidum, the occipitoparietal sulcus, and the lateral ventricle and choroid plexi, and have the calipers been put inner to inner, and then has the measurement been taken? Then you will say, okay, measured correctly, and it's a reliable finding. And then you say, okay, is there anything else wrong with the morphology that has been described? And then you decide whether it's isolated or it's not isolated. And this business is about making sure that 10 millimeters is the cutoff and not less than that is also important. Like 9.9, you won't say is abnormal, but you have to look at morphology as well. And morphology is okay, then you're comfortable. And then you go on to realize that, look, I have to make sure that my report has been done properly, that the report I have of my patient has a remark on neural tube defects, aneuploidies, because that can cause ventriculomegaly, intrauterine infections, and genetic syndromes. We always do an MRI for these, and in this case, we do an early MRI. And only after all this is done, do we say it's isolated or not, which means that the invasive procedure would have already been done, and we wait for the invasive procedure results come. The invasive procedure should be for a QFPCR for trisomy 21. It should be for a microarray for the rare syndromes. And it should also, in a specific situation, make sure that you store up some of the CSF because you might want to study it for other infections. But a routine PCR for CMV should always be done for ventriculomegaly. And that is important. And that's the best way to go about this. Now, moving on, we do realize that when we look at an anomaly, it becomes the responsibility of the obstetrician to either choose someone who can give you all this information or have this knowledge yourself. And what is this? Is that whether you have unilateral or bilateral, it doesn't matter, it's serious enough. If you have a bilateral asymmetric, which is difference between the right and the left to more than 2 millimeters, that has a bad prognosis because it usually reflects cortical destruction. Male predominance is more, but the outcomes are, not so bad in either, so it doesn't really matter. So we don't bother about doing a sex determination for these. Gestational age diagnosis doesn't matter, and therefore, whenever you do it, it becomes serious, and therefore it needs a full investigation. Now, we know that we have this working list: structural abnormalities, in utero infections, and aneuploidies, and therefore we must progress according to this and do the investigation that I suggested, which means a good detailed scan, an MRI, an invasive procedure. You might postpone the MRI till the results of the invasive procedure come in. That's justified. But somewhere along the line, in case the patient decides to carry on, there is an MRI required latest by 26 weeks of gestation. Because we don't want to miss any of these, it's important that beyond the initial evaluation by microarray, infections, and QFPCR, we must actually discuss with the geneticist that, look, I don't find any other finding, but do you think for any of these there should be? And then the patient goes for an interview to the geneticist or comes back to you, and you make a pedigree and decide and look at photographs of individuals affected in the family with this or any other disease, and then decide the best way to handle this particular abnormality. So basically, we will do all of this, but equally importantly in managing an anomaly is that the moment you find a finding, make sure there's been a meticulous scan and that the fetus has been referred for a neurosonogram, which is a highly specialized evaluation of the cranium, including a transvaginal scan. You need a genetic consultation and an infection screen, but before that, there has to be counseling. When these reports come in, counseling. Then, in case the patient decides to carry on, serial evaluation and counseling. The essence of managing lies in counseling. So, as you're learning lessons on what to do, a good place to do a scan, the right time to do a scan for everyone, make sure they're following a protocol, make sure you're aware of the limitations, make sure you extend the investigations in that situation, and counseling. And let's see now some more examples on how we can handle all of this. We can look at charts like this, which are available on the internet, and learn for ourselves by just Googling. If our patients can Google, why can't you and me Google and get answers like this? Remember that imaging has gone behind, not only 11 to 14 weeks, but 7 weeks. And here I see that, okay, I know this is 8 weeks because I know my posterior cranial fossa looks like this, and the brain looks odd, but I also see ectopia cordis, and I also see something herniating here above the level of the insertion of the cord, and I see very little abdominal wall below that. So I know I'm looking at a complex anterior abdominal wall defect, an abnormal brain, and perhaps I'm looking at a very early pentalogic cantrell, a little more fullness of the rhombin cephalon here. So diagnosis is going to as early as that. We can see ventricular systems by new technology. We can turn a switch and show ventricular system as early as this at 9 or 10 weeks of gestation. And we can pick up here a dilated fourth ventricle as early as 10 weeks of gestation with the monoventricle, confirming for me that this is truly a holoprosencephaly. So it's going backwards, but at the time of the anomaly scan, I must be able to pick up neural tube defects at about 99%. The next important structure I'm going to discuss is the agenesis of the corpus callosum, because you see it about once or twice a year and you have no idea. And then by the time the patient gets conclusion, she's 26 weeks of gestation, which is sad. So what is this? The corpus callosum is marked in the brain by a cavum septum pellucidum, which is this space here. And it's located in the front of the brain. It's rectangular, has prominent walls, and usually is twice as long as wide. And if it's not got these details, then you see there's an abnormality, and it should always be seen by about 20 weeks. But definitely, we end up seeing most of these by 18, 19 weeks, and therefore we look for it at the time of the anomaly scan. And if it's not right, then we start looking for abnormalities of the corpus callosum, which may be either a dysgenesis, a partial agenesis, or a complete agenesis. And then the fetus moves to a different level, which means no longer enough for the anomaly scan. You need to refer this for a fetal neurosonogram, which are additional views, which involves the use of color, which involves the use of 3D, 4D, and MRI, which also involves guidance towards possible genetic testing in case the need arises. And that is what I have shown on these slides here. A lot of this can be seen vaginally. Sometimes it can be seen in thin abdomens transabdominally, but this is the way we like to look for this abnormality. This is how the corpus callosum appears. And in our axial view, it is seen as a rectangular structure here between the two horns. So this is the kind of detail that is now available, and you should make sure that you refer cases for anomaly scan to someone who can give you this kind of detail. Otherwise, anything else is a compromise. Like I said, we might use color to demonstrate in agency corpus callosum. Is my pericallosal artery showing nicely like this, or is it not? And then, of course, a transvaginal scan, which often shows things nicely, provided the fetal cranium is in the deep in the pelvis. So these are the things that you have to specifically consider when you're making this. And therefore, do remember that ultrasound is no longer that simple, but it's not that complicated either. But in a given situation, you have to choose a center for anomaly scan that has the equipment. So we no longer just depend on a standard 3D ultrasound transducer. We use low-end or high-end 3D. Otherwise, 2D is no longer enough. We often use transvaginal scanning. We use superficial path scans like a 9 megahertz linear transducer. And then we use single firing transducers like I've shown here. And these are important. And therefore, the referral must be to a place where all of this is available. And if you're doing your scans yourself, please remember that there's a level of expertise to be maintained. Otherwise, it is wiser to leave this out. So again, that comes under management. And when you ask for MRI, it's not any old MRI. It cannot have a 0.5 Tesla MRI. Most of these studies would require a 1.5 or a 3 Tesla and a specific situation. Like in corpus callosum, you need tractography, which means that if the corpus callosum, which connects the left to the right, has parts missing, are these fibers then going to the back and coming back? So if there is a communication, then the prognosis is good. Or are they not? Is there complete interruption? And that's called tractography. And therefore, you will make your referral to a place where MRI tractography is available and is being done by a person who's familiar with how to handle things like this. This is what the geneticist will tell you, and it's an impossible list for you and me to handle. And therefore, I normally suggest always consult a geneticist whenever you have a complicated anomaly like this, and document in your clinical notes that, look, this is the report from the radiologist, and this patient is referred to a geneticist, or in case that it's far away city, or you're in a tertiary level town, or a much smaller town, or a rural practice, then you communicate with the geneticist yourself, inform the patient, and write down that, yes, we have discussed this with the patient, and so on. And then remember that there is this element of teamwork. So if I find that the corpus callosum is missing, my midline structure is missing, I have an interhemispheric cyst, I have a dilated lateral ventricle pointed, and I have here a cataract, then I will do a 3D of the face and see whether the nose is depressed or not. And I will do an MRI to see where these fibers are going. Once I've done that, I will have a diagnosis, either CMV or genetic. If the CMV is negative, I start thinking of only 3 conditions, depending on what I get from my geneticist. And the geneticist will tell you that, look, you need to do a few genes, and we must include the Miller-Dieker complex, the CBSE, and so on. But depending on what I get positive in those genes, which they will do in terms of an exome sequencing, or just a specific gene sequencing for that particular problem, then you know that you could either have a Fukuyama, a Walker-Warburg, or a muscle-eye brain. Difficult names to pronounce, difficult to remember, but either you could consult a fetal medicine specialist, or a radiologist with a special interest in fetal medicine, a sonologist with a special interest in fetal medicine, a genetics person who takes a much wider interest, or just a colleague who has more experience, and it works out well. Or you could call on the phone and say, okay, what's the genetic aspect? So remember that managing anomalies is about communication and having your own teamwork. Not everything can be classical, and not all of these have simple everyday names, and it's difficult for the practicing obstetrician to remember this. Here, for instance, is a fused ventricular system, non-cleaved as we say, and I see a corpus callosum, but I don't see a cavum septum pellucidum. So if I don't see it, then I know this is septo-optic dysplasia. I look automatically to see whether I see the optic chiasm, which is possible now to see easily by an experienced radiologist. And then I have my diagnosis. And then I say, okay, poor prognosis, maybe we will do a few genetic investigations and then send them on. So again, like I said, the basis is a good medium end ultrasound scan supplemented by a high-end ultrasound scan and genetic inputs. In the brain again, once upon a time, if I saw any of these, I would tend towards giving a poor prognosis. Hole in the back of the brain, hole in the back of the brain, hole in the back of the brain. What ultrasound is done now is included always a mid-sagittal view in the standard scan to be able to identify that in this particular individual with a hole in the back of the brain, this fetus shows a completely normal vermis of the cerebellum. So this is merely a Blake's pouch cyst, which is a congenital variation, which will disappear. And even if it doesn't disappear, it has an excellent 100% normal prognosis. In this one, I don't see a nice globular cerebellum. Part of the vermis is missing, a larger communication. So I know that this is verminogenesis, and that 50% will do badly and 50% will do poorly. And 50% will do all right. And if I have an upturned small cerebellum in a large space here, then I know I'm looking at Dandy Walker, where 90% of them will have a poor quality of postnatal life, and therefore I can prognosticate immediately and tell them there and then. But I will always combine it with a neurosonogram, with MRI when necessary, with genetic testing when necessary, and then give a full prognosis. Remember that your sonologist might actually measure angles and try and differentiate between these, and that's possible on the mid-sagittal scan. So if it's not clearly evident, then we use angles also to do this. So always choose to do excellent scans or refer them to scans to places where you can get a good result, and counsel your patient that, look, I'm not sending you here because I have anything to gain from it. I want a good report for you. You may or may not be a high-risk patient, but I want a good report, and therefore these are the people you can choose from in this particular given area. Moving on to the face, a mid-sagittal reconstruction is great. The face is not included as part in many protocols, and that is sad because there's all these conditions: sloping forehead, proboscis, missing nose, a small chin, and so on, which have a horrible prognosis. And the face is the first thing that hits the patient, and they will never forgive you for this, or at least most of them will not, if the baby survives. If the baby doesn't survive, there'll be enough people provoking them. So part of managing anomalies is to be familiar with the fact that, does the place where this scan is coming from have face as part of the protocol? Or you can call them and say, did you see the face as well, or do you not routinely see the face? And then guide the patient accordingly. Moving on to the neck. Now here, it's not enough just to say that, okay, there is a mass in the neck. It has to be the anterior, which is thyroid, lateral, which are usually jugular venous lymphatics, or they can be angiomas, hemangiomas, and lymphangiomas, or posterior, where they can be neurogenic in origin. And then we say, okay, there's a goiter here. And then the thinking doesn't stop there. Because when we look at this, we do realize that if it is hyperthyroid, maternal medication is enough. If it is hypothyroid and there's this large goiter, then you might need to extend your study to actually make sure that it doesn't grow too big to asphyxiate the fetus after it is born, and you might need an exit procedure before it is born, or it cannot get delivered because the head cannot get flexed, but to actually do intraamniotic instillation. So it's wise to have someone in fetal medicine to be working with you who has a fairly extensive knowledge, or to have someone who's a radiologist who works and does interventional procedures who can guide you correctly, or just Google. And the internet is a great friend of ours today, and that is the way you'll end up managing anomalies, just not that, okay, fetal goiter review after 6 weeks. That's not enough of managing an anomaly. You have to get to the bottom of the anomaly. The first thing that would be is an amniocentesis at the time of wanting to give, first is maternal evaluation of thyroid function, or evaluation of maternal thyroid function. And the second is amnio to find out what are the TSH levels there, what are the T3, T4 levels there, and then intraamniotic instillation of thyroxine, which is available only for thyroid storm. So it's not easily available. It comes as a liquid and available only with thyroid storm. Thyroid storm is rare, but in Delhi, for instance, it is easily available, and we've used it once every 3 years or so. Remember that the pediatric surgeons are another great group to work with. Pediatric neurologist, pediatric nephrologist, pediatric surgeon, pediatric counselors, neonatologists are all part of a great team that can help you in case you don't have other expertise available. But pediatric surgeons should form an integral part of the team, because we now have the American Pediatric Surgical Association, which says, this is the protocol I would like. I would like you to exclude, for instance, in a mass in the neck, whether there is hydrops, whether there is a stomach, whether the mass is cystic or solid or calcification, and then I can treat this. And there you go on. And then we now say that for neck masses, we always ask for an MRI, but later in pregnancy, closer to term. And we don't do it immediately, because it's for deciding which fetus will require intubation before it is born, which means that you do hysterectomy, do the intubation, and then the fetus gets delivered so it doesn't asphyxiate. And then, because it has a placental supply, you can take your own sweet time to intubate, but the guide to intubation will depend not on ultrasound, but on an MRI. And therefore, it's nice to have a good pediatric surgeon on board when you're managing such an anomaly. And there are indices that the radiologist uses, and they can tell you how severe is a mass in the lower part of the neck and the upper part of the thorax. And they have these indications on the internet, and you can use those. Moving on to the thorax, remember that there is the heart, the lung. The congenital adenomatoid malformation, which is that it has a natural history. The CPAM can be a homogeneous or a mixed echogenicity lesion, or one with large cysts, and we measure the volume of the CPAM by height into width into length multiplied by 0.5, which is standard calculation of an ellipse, and we divide it by the head circumference. And depending on this result, if you have a CVR, which is less than 1.6, then it's a favorable prognosis, likely to go absolutely okay. And if you have a CVR, which is more than 1.6, then you start thinking in terms of increased risk of hydrops, increased chance for either fetal or neonatal surgery. Fetal surgery we hardly do anymore in this condition, and so on. And therefore, warn them that they might need to get delivered in a tertiary center where all this care is available. That is very, very important. Now, some people go ahead and divide it differently. You must know which center to associate with. Some great guidelines come out from the Children's Hospital of Philadelphia in the United States of America. Remember that you could do nothing and still have a perfectly good outcome. You could have steroid therapy, the same as we do for lung maturity, and you could give it when you diagnose, and in a large number, this would regress. Initial studies are very, very encouraging. Later studies not so encouraging. Now we've sort of formed a level and say, okay, well worth a trial at that stage. A thoracentesis, in case there's a large pleural effusion or there's a large cyst inside it, then you do resection, which we hardly do, and early delivery, which we like to avoid unless there's been a rupture of membranes. And then this exit procedure, which I was saying, that just before delivery, we do a hysterectomy incision, intubate the fetus, and then deliver it while it's still on the placental circulation, and very useful in this condition. And you have a nice chart like this, which is free on the internet, on how to manage macrocystic, which is the large cystic versus the small cystic CPAMs, and whether it's less than 32 weeks or greater than 32 weeks. Now here, there's a very, very, very zero chance of an associated genetic abnormality, and therefore you don't need genetic evaluation if it's been identified correctly. And therefore I chose this, one for natural resolution, B for antenatal intervention, and C for type of delivery and place of delivery. And of course, simple interventions like antenatal steroids given at the time of diagnosis. Now, another thoracic lesion, which you and me face often, and a very glamorous thoracic lesion because they treat it in the West by putting a tube into the thorax via the trachea, and they leave it in the trachea. And then because the fluid in the trachea gets blocked, the lungs grow better. We know that lungs will grow only when there is tracheal fluid and bronchial fluid. And therefore that has now come up. And then when we see a hernia, then we calculate a prognostic feature called a lung head ratio, because although we have a long list of what can be a poor prognostic factor, what is really useful is the lung head ratio as an index of pulmonary hypoplasia. Also remember that the other poor prognostic feature, which is pulmonary hypertension, although we calculate the indices of the pulmonary artery flow velocity waveforms, may not be so easy and reproducible. So therefore we depend on the lung head ratio, and you can use a standard referral, like we use perinatology.com or parameters.com and so on, and you can make this calculation, or you can actually just do a trace area of each lung and divide it by the head circumference, and all of this in millimeters, and you get the lung head ratio. And then we put it in terms of what we would expect at that period of gestation, because the lungs and the lesion are going to grow, and therefore you want to have a comparison. And once you have that, you can prognosticate. And if the LHR is greater than 1.4, excellent survival rate. Less than 0.9, you usually have to think in terms of how much ECMO to organize and so on. And between 1 and 1.4, difficult to say prognosis. So this must be part of your ultrasound report, and insist on it, so that then you can manage this particular condition intelligently. Now, in this situation, it's different from a CPAP. You need a detailed anomaly scan, of course, and a fetal echo, which we now almost do for everybody. You need an amniocentesis to exclude trisomy 21 and syndromic association. Therefore, you do a microarray along with a QA-PCR. You need an assessment of pulmonary hyperplasia, and today this is done best by MRI. So the one indication from an MRI is that somewhere around 26 weeks, you start doing it, and then you repeat an MRI later to find out the extent of pulmonary hyperplasia. The LHR is used mainly for a diagnostic and early prognosis. MRI is used for late prognosis. The treatment that we do here is to prevent hypoplasia. Prenatal surgery was recommended, has been abandoned. Fetal tracheal occlusion by doing fetal surgery has also been abandoned. And now what we do is an ultrasound guided tracheal occlusion, or some people do it with a fetoscope, and then you block the trachea. But do remember that these need to be removed before the baby is born, or the baby will not be able to breathe, and therefore the delivery has got to be there, and therefore either the patient gets transported to wherever she has to be after 32 weeks of gestation, because they are often prone to premature deliveries, or you have the expertise and guide them accordingly, because you can't just do it once and say, okay, now go home to your village and sit over there. So it's very important to have this knowledge of up-to-date procedures as you go forward in obstetric practice today. Now, sorry for this repeat. Remember that the same thing applies to fluid collections anywhere. You find fluid collections, you must understand that yes, these could be pleural effusions, pericardial effusions could be part of hydrops, and you follow the same thing. Look for anomalies, do a cardiac evaluation, do a genetic evaluation, consult a pediatrician, neonatologist, pediatric surgeon, consult maybe the genetist for sure. The laboratory will tell you how much fluid, what to test, what container to send it in, is the laboratory open on that weekend or not, then the job is complete. So all this knowledge of your entire working environment and your teamwork is important in managing an anomaly. So all of this would then apply for a pleural effusion, it would apply for a pericardial infusion, and so on. And if it's a persistent pleural effusion that doesn't go away with one tapping, then we can even put in a tube in place. And we don't do it in this way that's shown in this, where everything is placed anteriorly because the fetus pulls it out, but we do it from the back through an intercostal space where the fetus would not be actually pulling it out. But it's a very rarely indicated procedure, and we normally manage with one little thing. Now, the other thing in the heart that we need to handle is, other thing in the chest we need to handle is the heart. And there is a difference between cardiac evaluation in the second trimester scan, which includes situs, size, axis, rate and rhythm, contractility of the myocardium, a 4-chamber view, outflow views, and a 3-vessel view or a 3-vessel trachea view. This is not a fetal echo. This is what we evaluate as routine scanning. If we find a problem here, or there is a background of a problem, then we say, okay, we need a fetal echo, where we add on making sure that we look at venous circuits, we look at the arches, the area behind the heart, we add on Doppler, measurements of the heart and Z-scores, that forms a fetal echo. So it's a separate referral. It can be done by pediatric cardiologists, it can be done by sonologists, it can be done by fetal medicine specialists, by good radiologists. You have to find your own person. But do remember that there is a difference in cardiac evaluation at the anomaly scan compared to a fetal echo. And yet we will still identify almost 90%, but we will not identify 100%. And that is important to know. And we always use additional evaluation, not just a 4-chamber view as I show you here, and not a low-end view like this. You must get used to making sure that the images that are available for you are magnified, that a whole fetus has been looked for, that an appropriate preset has been done, and that the initial protocol has been extended wherever necessary. If it has not been done, then please do send for a second opinion. So here we put on a special software to look at the heart. We then magnify it appropriately, make sure it occupies most of the screen, magnify it even further, go on to then assess what is happening in the other views, add on color Doppler because it's a very useful procedure, add on 3D and 4D when necessary because 3D is a great problem-solving modality in the fetal heart, and therefore involve a pediatric cardiologist, involve genetics because genetics has a major view, make sure that all this information you got from the radiology has been given to all these people, discussed at a personal level. It's very difficult because some people have the luxury of a great fetal medicine department where everything is available, marvelous. But how many of us in India can really boast of having that many in our city that they can handle everything? So you have to be the pillar that will then have support from these other pillars that will give you the right inputs. And then, like I said, genetics, pediatric cardiology, advanced evaluation, and so on. Remember that it's not just about high-risk groups. It's also about realizing that all these things can be drug-induced. So a drug history is very important. Diabetes is very important. The background of IVF and obesity is important. Infection is important. Then fetal causes, any finding in an ultrasound scan should say, okay, I need to look at this much better. And yet, remember that and the low risk group is the high risk group. And therefore, anything that's a little up and down requests for a fetal detailed cardiac evaluation or fetal echocardiography beyond what is seen. Remember that a family history affects this. Remember that there is a large background of what the previous lesion was, and so a detailed history is important. And you can take that, ask for the patient's previous reports, and if they are beyond your scope, refer them to a specialist or call a geneticist and find out what is going on. This kind of genetic evaluation is different for each. Like for some, you might just need a microdeletion 22q and a trisomy 21, and your lesion is handled. Other situations, you might have to really move on to other things, depending on the family history, depending on the findings, and therefore it's wise to involve someone who's more specialized. Remember that at any time, in evaluation, particularly for the heart, a low risk will move into a high risk, and that is important. And you then have to stratify what you need to do. You can't straight away say, no, I will do an echo for everybody. That is not justified. Now, a few more cases before we close. Omphalocele in the second trimester. Here is this girl who comes in and she presents at about 19 weeks. The first time. Small omphalocele, and it contains bowel and contains nothing else. And her husband and relatives wanted termination. You told them that, look, no, I want to investigate before I terminate, and we need an amniocentesis first. Now, they don't listen. They go, and they don't wait for all these other things to come in, which means that did my original ultrasound scan exclude gastroschisis? Did it exclude cardiac lesions? Did I look for markers of aneuploidy? Was there a history? Is there a pedigree? Is my counseling okay? What is my genetics shown? And then delivery at a tertiary care center. That would be ideal. Otherwise, you're in trouble. This patient, for instance, that I was describing went on to a termination and she never conceived again. And we might have been okay by just repairing an omphalocele because there was no other condition. Of course, if you find other abnormalities, like in this case, you have an omphalocele, clenched fist, omphalocele here, clenched fist here, we know we're looking here then echogenic multicystic kidneys. We know that this is trisomy 18. We will still, before we terminate, reconfirm the karyotype and then terminate a pregnancy. But these are simpler things to handle. But again, like I said, great contact with the person doing the scan, or if you're doing it yourself, meticulous attention to detail, invasive procedures on the guidance of a geneticist, and then that would be proper management. Of course, we have now a scenario in the first trimester, but that is beyond what we're doing in today's structure, in today's webinar. Now, the second thing that you often find in your reports is a fluid collection in the abdomen. Now, here we look at it differently. And if the location is important for me, so if it's in the right upper quadrant, I would think of association with the umbilical cord and the hepatobiliary system. I would also think in terms of adrenal atresia. And then I would check to see that my sonologist has gone through all of this. If I find it in the mid-abdomen, then I would start thinking in terms of a mesenteric cyst or urachal cyst or a urethrocoele within the urinary bladder. If it is on the lateral aspects, I would start thinking of an ovarian cyst. Again, for ovarian cyst, look at the genitalia and see whether they've been looked at, or call the person to communicate, or if you're doing your own scans, look at the genitalia. We may not disclose it to the patient, at least we know in our head that this is ovarian cyst and just needs surveillance after birth, and most of them will go away. The other thing that we often come across is a report of urinary dilatation. And for this, we now have a very straightforward guidance from a multidisciplinary consensus group from Southeast Asia that got together and gave us a urinary tract dilatation classification system, where they give us the number of weeks and they give us the amount of dilatation, 4 millimeters, less than 7 or less than 10. And that would depend on the number of weeks. And then you look at the rest of the system, central dilatation of the calyces, parenchymal thickness, subjective evaluation of echogenicity, whether the ureters are dilated, the bladder is dilated or not, and whether there is oligoamnios. And then you have a protocol that comes into place. We also know that when we look at these, they could be transient, and therefore we might ask the sonologist to repeat it after a while. For instance, when the bladder empties, in case it was not looked for. But more important, we do understand that the level of obstruction has to be identified, and also to look whether it's unilateral or bilateral, associated abnormalities and quantity of amniotic fluid. And then the decision depends on the maturity. At the level of the anomaly scan, you need to investigate extensively. Later in pregnancy, we look for maturity. And we know that for an isolated pelviectasis, the risk of chromosomal abnormalities is not too high. And only if you have a high calculation for your trisomy 21, that means a baseline high risk, 39 years old, 41 years old, abnormal double marker, abnormal quadruple marker, associated abnormalities such as other markers like echogenic bowel, or you have a cardiac defect, then you do genetic investigations. Otherwise, you don't panic about a little bit of dilatation of the urinary system. You just do a routine follow-up. And then, of course, you have a very rare incidence of some of the other syndromes, and those are so extensive in terms of multi-system involvement that you can never really miss them. Now, accordingly, then you will decide that if it's a bladder obstruction, genetic investigation, upper obstruction, not really so much of a genetic investigation. And the other thing to realize is that in kidneys that have trouble and kidneys that have either spaces or cysts or dilatation, you have to consider whether they have a background of what is now called the ciliopathies, related genetic disorders. And here again, it's difficult for you and me to understand this. We need the inputs of a geneticist, because here is a list of what we normally see. I'm not repeating this because that doesn't make sense in a webinar. It's something that you can, of course, Google and find out, but it's nicer to have a hands-on geneticist help you to handle these situations, because there's an overlap between these syndromes. There's lots of big names there, and I won't really repeat them because it makes no sense. We used to, in fact, do a lot of investigation of these patients with invasive testing. And we realized that's not important anymore for kidney function. Kidney function does not depend on echogenicity, degree of dilatation, oligoamnios, and so on. What it depends on is the first trimester findings. And last last year we discovered, or last year actually for publication, that if this fetus had a thick nuchal translucency, or the bladder was more than 12 and not 15 millimeters, and there were umbilical cord cysts, those are indicators of poor kidney function. So that's how our knowledge has changed over the last few years, and that's what we use as of today. Now, that protocol that I was talking about, the urinary tract dilatation protocol, tells you exactly what to look at and when to repeat the ultrasound scan. And most sonologists and fetal medicine experts will now tell you, okay, repeat at 28 weeks, or repeat at 32 weeks, and repeat at 36 weeks. All of this is available as the kind of protocol that I have shown you on this particular slide. And this is again available as a free download on the internet. It tells you not only what to do before a baby is born, but also what is to be done soon after delivery. And we know that soon after delivery, there is poor urinary output, so the dilatation may not be seen. So what we really need to do is to assess how best to handle this in terms of about 5 days to 7 days after delivery, or a few months down the line. And all of this risk stratification is mentioned in the protocol for a postnatal evaluation as well. So we have a low risk urinary tract dilatation, we have intermediate risk urinary tract dilatation, and a high risk. And depending on these, you know what investigations are to be done further on. Now, before I close, a bit of discussion on what we see every day. Minimal pelviectasis. We know that these were indicators of Down syndrome, and we now don't use this old chart anymore from 2003. We use a new chart, which is the Agatha-Cleo's chart, which tells us that for every finding that we have of these findings for trisomy 21, there is a detection rate. That means how many of babies with Down syndrome would have it. Then we multiply the baseline chance of aneuploidy, either from the maternal age, if we have nothing else available, or the first trimester risk calculation if you have nothing else available, or first trimester plus other risk calculation, and then you have the new one because you've added on a quadruple and so on. And then you look at this chart and you do a multiplication. For every finding that you have a multiplication factor which is negative, that means a division factor. And for every finding that you have, the risk goes up. And therefore you use those, and depending on that, you will decide on how you will panic. So a lot of these findings then we now ignore. And let's look at these for the sake of completion before we start advising invasive testing just for these. The echogenic intracardiac focus is a very common finding. Left ventricle, right ventricle, multiple, single, large. None of these matter as an isolated finding. They do not even need a fetal echocardiography. You just need to say, okay, no other finding. My biochemistry was normal. She's not 42 or 49 years old. Happily carry on. Nothing else to be done. The other thing is that we find it so common in our Asian patients. Always remember that bias and don't unnecessarily suggest invasive procedures. Echogenic bowel, on the other hand, is not so bad for Down syndrome, but quite bad for CMV, or the fact that there's been a previous bleed, or that you have cystic fibrosis. So it has a much wider workup. In that case, it's not just a trisomy workup, but a complete workup for CMV, with Doppler to exclude mesenteric ischemia, for a family history of cystic fibrosis, or a previous history of bleeding during pregnancy. And in all of those, of course, you do a workup, of course, for trisomy 21 as well. What about the aberrant right subclavian artery? It's something we like to look for, and not difficult to find because we now do routine color, and you can even locate it in the first trimester. And it shows up as a nice little beak like this. Again, by itself, we don't panic. By itself, we say, I will look at my previous risk, my age factor, my biochemistry, my first trimester, my quadruple test, my integrated test, or a first trimester penta if I've done one. And then I add on this, and then I see, do I need invasive testing or not? Of course, you could send them out to a cardiologist because some of these might form loops and stridor postnatally, and the patient will say, well, you were only talking about trisomy 21 and you forgot about the stridor. My baby has terrible stridor and I don't know what to do, and why didn't you want me? So it's nice to tell them, yes, genetic and non-genetic. And how can you do this? Knowledge. How can you get knowledge? Teaching and education, like the wonderful Pune Obstetric Gynecological Society is doing for us by these webinars. Same thing applies to thick and nuchal skin fold. We don't panic. We usually realize it's a major marker out of all those markers, and therefore invasive is encouraged. But again, I look at the background. So if the patient's had an NIPT, for instance, then I don't get worried about a thick nuchal skin fold. Then I know it's a normal variation, and I look for other things. I may or may not even do an invasive until the patient insists, and I say, no, this is normal variation. Nasal bone is a good marker in the second trimester, and that means the portion we're talking about. And therefore, then again, we make a calculation. Never just, oh, absent nasal bone, amniocentesis. No. Absent nasal bone, this is your risk. Patient to decide whether she wants invasive testing or whether she wants non-invasive testing, and tell her that, look, there is a time frame. We have to finish all this testing by this time, and you might need to go to the court to ask for permission. So that counseling becomes as important. But this chart you have to keep on using, and remember that the more the findings, the greater the chance of a problem. The lesser the finding, the lesser the chance of a problem. So basically, to wind up the formal part of this talk, we do a complete workup of each finding, including imaging and genetics. We look for associated abnormalities. We don't limit the use of technology to come to a complete diagnosis. We remember the natural history and the newer advances in knowledge that are there. And then it's counseling, counseling, and counseling, and let the patient decide for themselves on what they would like to do. Remember that beyond primary antenatal care and routine investigations, there is quality ultrasound, inputs from genetics, inputs from the various pediatric and cardiac specialties, post-mortem studies where necessary, and these should be encouraged, counseling, counseling, and counseling, and then you decide what is the advanced maternal care that this mother needs, what is the advanced fetal care that this mother needs. Sometimes masterly inactivity can be good enough. You can have in utero medical and surgical treatment options, which need to be worked out with a highly specialized person, postnatal workup, but importantly, remember teamwork. We cannot sit in towers and say, okay, I'm radiologist, I will not communicate with geneticists. I'm geneticist, and I will only give an opinion, send the patient to me with a note. Or the pediatric surgeons, the pediatric there we are.
Harshad sir, you need to unmute yourself.
Yeah. I think quite a mesmerizing talk. For the last 1 hour 45 minutes, we've just been listening to you with our eyes glued. Ashwini, yes, if there are any questions, I think if time permits, we'll take some.
I think we'll take just 1 or 2 questions because we are falling short of time.
Yes.
So the one question was, should we do 2 USGs if we decide to terminate for a major fetal anomaly?
In general, it seems to be a good idea to have 2 opinions, because you never know which is erroneous, and it's not necessary, it's not legally required. You have an opinion, but in the kind of medical legal environment we're living in today, it might be wise to have 2 opinions before you terminate. And then, of course, the usual rules of termination, that it's a late termination, 18, 19 weeks, and therefore we need the signature of 2 obstetricians.
Okay, so and how do we counsel in case we have 2 vessel cord in absence of any other anomaly?
I was so sure this was coming. That's actually my slide afterwards.
Okay.
So you see, a single umbilical artery is now not such a dangerous thing. You do a detailed scan, you do the detailed cardiac evaluation, you look for any other signs of aneuploidies, and you're happy. Also, the single umbilical artery does not cause growth restriction. We understand that. After all, the umbilical artery provides the placenta, and the placenta then provides the fetus. So you might not actually have any problem with the placenta at all. So we don't look at normality here, but I look at the type of the single umbilical artery. We tend to think the single umbilical artery is one type, and that's not true. There are 4 types of single umbilical artery. There's the usual type, one artery, one vein, which is the left umbilical vein. You could also have 2 veins and 1 artery, which is type 2, where you have a left umbilical vein, you have a persistent right umbilical vein, and you have 1 artery. That's a dangerous type. And you might have all kinds of abnormalities. And in this situation, you can also find an artery, a single artery arising only from the aorta directly. You won't find anything around the bladder. And yet it will be a 2-vessel cord. So these are the various types, 2, 3, and 4, as we say, where the problems are much more. But in your standard single umbilical artery, you've excluded signs of cardiac disease, you've excluded aneuploidies, and you've excluded a heart, a kidney problem. You're very, very comfortable. The only thing that you need to follow up for is that there is this high association of this, there is this high association of single umbilical artery with maternal diabetes. So you might screen that woman for diabetes in a more vigorous fashion. But otherwise, we're not scared of that anymore.
And unilateral choroid plexus cyst?
Well, whether they're unilateral or bilateral, big or small, we just ignore them completely. If they're an isolated finding, if I find any other finding, like I find that the fist doesn't open, or I find a cardiac defect or a renal defect, then I get worried, or I find a growth restriction. Otherwise, I ignore isolated, and we call them isolated then, isolated choroid plexus cysts.
What is the ideal time when you would like to do a fetal cardiac echo?
Yes, so there's no doubt that visualization is best at 22 weeks. But what I do is, if there is a previous history, then I might even start my cardiac echo detailed evaluation at 12 weeks. I might repeat it at 16 and so on. But wherever necessary, and if I find something I'm suspicious about at my 18 to 20 week scan, I do an echo at the same time, in the same sitting. You counsel the patient, you speak to the clinician, and say, okay, I find this problem. And then I do an echo, very rarely with a patient with high BMI or a persistently, unfavorable fetal position, we might run into trouble. Otherwise, I do an echo at the same time. And if I'm not satisfied, I will call the patient back at 22 weeks. Otherwise, 18 to 20 weeks is a very comfortable time to do a fetal echocardiography.
Okay. I think, sir, we'll wind up.
Yes.
I think Dr. Khurana, thank you very much. It was a pleasure hearing to you, and an excellent session.
Thank you very much.
Thank you so much, sir. We would also like to thank ICOG for crediting us with 1 credit hour for this. Thank you so much, sir.
Thank you.
Thank you.